I think, as most of you know, I've been using processed EEG monitoring, by which this is devices like the BIS monitor, the Narcotrends, the SedLine, etc., for about 15 years now, since I was a registrar in Sheffield. And it's been a routine part of my practice now for about 10 years in every patient, every time. And I've always found it very informative, really, a bit like a big drip and an ET tube. I've never regretted using it. And a while ago, I started taking an interest in the raw EEG and started to think what I could learn from looking at that real-time measure rather than just looking at these index values. I noticed that there was quite a difference in the waveforms between different patients. Here, a 33-year-old male, and on this side, a 70-year-old female having a laparotomy. And although the index values are fairly similar, it doesn't take a particularly keen eye to notice that these waveforms are very different. And both of these in their own way are actually demonstrating appropriate levels of anaesthesia. So I wondered to myself, why do some old people look a bit flatter? Some other old people might have very much younger looking EEGs. I noticed that these young looking EEGs with these nice big tall waves seem to wake up really nicely. And some people with flatter looking EEG waveforms seem to take a bit longer to wake up and perhaps not be so sparkling. So I thought I'd tell you a bit about what I've found out. I've done a few talks for the AAGBI now about this, and this is a development of that. So much of this may well be new knowledge to folk, which is probably a good thing. But this is very much at the leading edge of where we are with EEG technology. So don't be too surprised if perhaps some of it's not familiar. And I hope to build on all of this with some more training over the rest of the year as will become clear. So just to orientate you very quickly, this is an EEG. We have a baseline here, which is set at 0. This is an isoelectric line across here. And then we can go plus 50 or minus 50 microvolts on the screen. It takes 4.4 seconds for the wave to move from one side of the monitor to the other. I know because I've measured it. And what we're talking about when I'm talking about amplitude is the height, if you like, of this wave. And we can see this wave's really tall and this wave is really small. And we'll just go over what that means in a few moments' time. So what we're going to cover today, we'll go through the effects of age, comorbidity and frailty on the EEG, recognizing burst suppression, identifying the vulnerable brain phenotype, correlating this vulnerability with the risk of suppression and then delirium, and hopefully enable you to get more from your processed EEG monitor. But firstly, a reminder of some nomenclature and then a mention of a couple of clever gadgets. So with increasing depth of anaesthesia, for want of a better term, the brain moves from a state of producing high frequency oscillations, which are fairly random and discoordinated, to producing slower oscillations. And these are described in frequency bands using these lovely Greek terms, which are actually the reason that they're not in alphabetical order, for want of a better word, is that alpha was the first discovered wave. So it was named an alpha wave, and then presumably in order of their discovery, they were named according to the Greek alphabet. But the dominant frequency we see in our patients in theatre will be these beta waves. For somebody who's relaxing with their eyes closed, they can go into a state of a dominant alpha rhythm, which is detectable at the back of the head. It's an occipital dominant rhythm. The beauty of anaesthesia is that these waves become dominant in the frontal cortex, just where we're putting our stickers. Absolutely perfect for us. The waves we're particularly interested in anaesthesia are these ones, these slow and delta waves, and then these alpha oscillations. And these are readily detectable on the screen. If we look at this here, I've turned the filter off and I've drawn on this slow wandering baseline here. For these two oscillations, 1 peak, 2 peak, are our slow waves. We know they're slow waves because, as I said, this is 4.4 seconds from one side to the other. There's just 2 of them. 2 divided by 4.4 gives us a frequency of 0.5. These are slow waves. Superimposed on those is this sawtooth baseline, where if you're a bit of a geek and take a photo of the screen and then count them, you find there's 46 of them. Divide that by your 4.4, and that's 10.5 hertz. So we've got slow waves and alpha waves on this picture, which this is the picture that we see with anaesthesia, a picture called thalamocortical dissociation, which is a subject for another talk, but is which is fascinating. Now, what I'd like to do over future sessions is build on this and get people familiar with looking at the raw EEG and interpreting it. But fairly soon there's going to be an update to the BIS monitor user interface, which is, to be fair, around about 15 years late in coming. And it's going to reintroduce some of the old features that they've had in the past. Now, I've got the all of the teaching stuff from the BIS company, so I can give you a sort of UK first look at what the new system is going to look like. We'll be the first in the UK to get it because we're BIS's biggest customer, and I tend to try to push for these things to come sooner rather than later. So this is what the new BIS interface is going to look like. It brings a few new things, which I'll mention to you in just expand on in just a moment. We've got this nice colourful display here, which is called a density spectral array. A couple of other parameters called spectral edge frequency and median frequency. Suppression ratio, which is the subject of a third of this talk, is going to be displayed continuously. And this thing here called suppression time, which is going to count for us how long our patients have spent with a suppression ratio of greater than 1%. And that's actually really very useful. On this side, this is a picture of a monitor called a narcotrend, and the charity has been very generous to us in funding the purchase of 6 of these monitors, which are particularly useful for our paediatric colleagues and for those of us with a real deep interest in EEG monitoring who are looking for some other parameters and the ability to record and export EEG for teaching and further review. Now, this density spectral array thing is really cool. So I'm going to spend just 2 minutes explaining what it is and whet your appetite for that. So an EEG waveform is actually a composite of more complicated waves. And if you remember from the primary learning about Fourier transformation of the arterial line trace, remember we could break that arterial line trace down into its components. And we could do the same with the EEG. And we've broken this particular one down into 2 different frequencies, our slow waves, as I showed you on my little picture, as well as these higher frequency oscillations. Now, that's interesting, but not particularly easy to interpret. So that can be transformed into something called a power spectrum. And this power spectrum shows us the amount of each of those waveforms. And this changes as we anaesthetize our patients and produces very characteristic graphs, which are actually agent specific, as I'll show you in a moment. And as somebody becomes anaesthetized, we see a movement from high frequencies into lower frequencies, and we'll see some characteristic patterns. Now, these diagrams tend to update on the machines about once every 5 seconds, which means it's not really very useful for assessing what has happened in the past and for getting a feel for the potential direction we're going. So these diagrams, which I think a little bit, I think of them a bit like those stages in the Tour de France, really, can be stacked up next to each other to give us a chronological recording of what has happened. If we turn the amplitude, the height, into a colour, we use warm colours to indicate more of a particular frequency and cool colours to indicate less of a particular frequency. And if you imagine each one of these pictures is stacked up as a line of pixels next to each other to produce a continual picture that can build up for minutes or many hours, showing us about the oscillations that the brain's producing. And this is a bit easier to look at than one of these. Now, it becomes very easy to recognise what adequate anaesthesia looks like, because these patterns are agent specific. So this is particularly cool. So all of our different drugs act on slightly different combinations of receptors and neurons and have different inhibitory or excitatory effects. Propofol produces a very particular pattern, which is thalamocortical dissociation. This is a delta alpha pattern. So we've got this lovely tram tracks, if you like, picture here of alpha oscillations and delta oscillations. When we use sevoflurane and start to get to around or just above a MAC value for that individual patient, we start to produce these theta oscillations, and we get this big block of red at the bottom. Dexmedetomidine is a funny drug, produces a deep sleep-like looking EEG, which is dominated largely by delta waves. And we can see if we look at the raw EEG that they all look a little bit different, but this density spectral array, which we'll all have access to soon, makes it very easy to recognize what's actually going on. Now, ketamine, if we look at this, this is what an awake EEG looks like essentially. And this is why ketamine causes all those problems with the Abyss monitor, because essentially it produces it's an excitatory neurotransmitter that excites the cerebral cortex and makes the brain look awake. The BIS monitor interprets these high frequency, low amplitude oscillations as wakefulness and gives you a high value, typically in the low 70s. This is called a gamma burst. This particular patient's having just an anaesthetic maintained on ketamine, and they oscillate between a gamma burst and then burst suppression. One of the nice things about using ketamine, particularly when you're using TIVA, is you can pick out exactly where you've given your ketamine, and you see a slight change in frequency as the excitatory effect of the ketamine interacts with the inhibitory effect of propofol. And about 2 minutes after your dose, you see a slight frequency shift. And that's something we'll expand on in a later talk. So what about the aging brain then? How does the aging brain differ from the brain in youth? And I think I'm somewhere on the continuum towards having an old brain, I think. So here's a couple of EEG traces, 5 seconds on each, a 36-year-old patient and a 93-year-old patient. And I don't think it takes an expert eye to recognize that the size of these oscillations between the two patients is very different, as indicated with these little red marks. The aging brain produces a lower power in these alpha oscillations, the ones that actually reflect what's happening in the thalamus. They, paradoxically, older patients produce more of these, some of these beta frequencies and some of these gamma frequencies, which confuses our monitors a little bit, as I'll show you in just a moment's time. But the take home from this is the aging brain produces smaller alpha oscillations than the youthful brain. Now, this is something called a coherogram. These are patients of all different ages from around about 18 all the way up to 90. And this is a single density spectral array for each of these age groups taken during the maintenance phase of anaesthesia that shows us how that alpha power starts to fall with increasing age. And once we get to around about 69, 70, there's a statistically significant reduction in alpha power with increasing age. And the mechanisms for this I've listed here. And with time, and with looking at the EEG, as I think we should all do as one of our essential monitors, one becomes able to pick up these trends and identify an old-looking brain and a young-looking brain. These are some of the patients that I've anaesthetized fairly recently. This is using something called a bifrontal BIS monitor, which gives the density spectral array. I've taken these images during the maintenance phase of anaesthesia, different ages, and I think we can see here this nice red stripe becomes thinner, reduces in frequency slightly, and then becomes very faint as one increases in age. This low band alpha power here correlates with poor preoperative cognitive function, as well as burst suppression and delirium, as we'll talk about in the remainder of the talk. This particular patient, though, just to mention, this is actually looks really good. To actually even be able to see an alpha band in somebody 94 is really good. This gentleman was absolutely pin sharp cognitively before his laparotomy, and on day one laparotomy, post-laparotomy was sat out, and when I went to see him on my pain round, he was offering to help the nurses look after some of the other patients who were around about half his age. So there is some wonderful evidence about cognitive function, preoperative cognitive function, causing measurable EEG changes. But brain age is not just chronological, it's also physiological. So here's two different patients I anaesthetized on the same day, both 40 years old, coincidentally this is, very coincidentally, 40 years old, both having the same operation, same technique, same day, same monitor. But we can see a difference here in between the strength of those alpha oscillations between these two patients. And this would give you something on the screen that would look perhaps a little bit like I've illustrated there. And this is demonstrating the brain age effect, as well as some intermittence and variability in alpha power. This red band isn't always constant, it does wax and wane as the brain moves between different states during anaesthesia. So these age-related changes can cause a bit of confusion to our monitors, because most, in fact, all but one, only the narcotrend has an algorithm that takes into account the way the brain changes with age. This is a lovely study from knee, 550 patients from 18 to 90 odd, put into different age bands, and then effectively clamped at an age-adjusted MAC fraction. So all these patients here are at one age-adjusted MAC. If you're 30 to 49, that would give you a mean BIS value of around about 40. But look what happens with increasing age. The BIS value for the same level of MAC gets higher. And in fact, for patients who are in the eldest age group, their BIS is some 3.5 BIS units higher than the younger patient. So the BIS can overread a little in older patients with the potential for increased volatile dosing. Why is this? Well, it's that beta power again. If we look at this study here from Schultz, Dr. Schultz, a married couple, anaesthetist and electrophysiologist, the brains and genius behind the narcotrend, have been looking at this for many, many years. And they demonstrated here, this is this beta power, the more awake, higher frequency brain waves. These are the stages of narcotrend that it measures in. D is adequate anaesthesia, E is deep general anaesthesia. They've demonstrated here that these older groups are producing a higher beta power than the younger patients, which is consistent with what I showed you at the beginning. The aging brain produces a different array of brain waves in response to general anaesthesia, which can confuse our monitors. Dementia, I think it's worth mentioning that dementia also adjusts the output from our BIS monitors. The patients with cognitive impairment have more slow waves and less of these higher frequency brain waves and higher power brain waves, which confuses the BIS monitor. So patients with dementia have a BIS value around about 5 units lower than their age-matched peers. And I think this really adds weight to putting the BIS monitor on prior to the induction of anaesthesia, so we can have some form of a baseline prior to inducing anaesthesia. So I always put my BIS monitor on before the patient goes to sleep. It's a wonderful talking point. Patients, I think, are quite impressed by it. And they always say, oh, you won't find anything in there, doc. Which lightens the mood a little bit. So let's have a quick look at burst suppression then. So what is burst suppression? Well, burst suppression is a pathological brain state which is not seen in health. It's a state of reduced brain activity which is associated with post-operative neurological disorders such as delirium, as well as potentially increased mortality, prolonged wake-up times, increased drug costs. And outside of ITU, some specific ITU indications, neuroanesthesia, it's generally considered to be potentially harmful and a state to be avoided. Fortunately, in healthy volunteers, it doesn't seem to cause any cognitive detriment. However, in our older patients, it seems to be more problematic. And a number of papers have illustrated an association between the duration of burst suppression and the incidence of delirium, although paradoxically reducing the duration of burst suppression doesn't always offset the delirium. So there's association there, but not simple causality. But we'll explore that in our vulnerable brain discussion in a few moments' time. This is my world record for lowest BIS value in a 26-year-old patient transitioning from an inhalational induction with sevoflurane onto propofol maintenance, just with an effect site concentration of 1 using Schneider's model, and I managed to completely burst suppress her, which will explain why that is in just a moment. Fortunately, however, in young patients with normal brains, this doesn't cause us any mischief at all, which is lucky. If you look at the line here, in fact, there's so little brain activity going on, we've picked up the ECG. We can tell that because of its regular, repeated and reproducible waveform. So that may be the lowest BIS you ever see. Now, the burst suppression ratio describes the percentage, when using a BIS monitor, of every 63-second period of time with a voltage of less than plus or minus 5 microvolts, so a flat line. And we move between a period of isoelectricity into a burst. And this is the thalamus desperately trying to kickstart the cortex back into life, if you like. These bursts are agent-specific in their morphology. Propofol's bursts are shorter and lower amplitude and require less ATP to produce than isoflurane. Isofluranes are very steep and sharp and quite prolonged, which is due to the small NMDA receptor effect that isoflurane has. It's not just our anaesthetics that can cause burst suppression, but significant intraoperative mischief can cause burst suppression too. This is a patient who suffers a 3.5 litre hemorrhage during liver surgery. You can see the BIS value fall as the suppression ratio starts to climb. There's a period of restoration of blood pressure here where the BIS value climbs and the burst suppression sinks a little bit before a little bit more bleeding before the situation is all resolved. This is transient hypoxemia during a case, during an intraoperative emergency, where the patient became desaturated down to around about 30%, and we see the BIS value fall, the suppression ratio increases, and when the scenario is promptly addressed and managed, everything's back to normal and the patient was successfully extubated at the end. But of course, hypothermia, as seen in cardiac, deep hypothermic circulatory arrest, will cause burst suppression, hypoxemia, hypotension, hypoglycemia, blood glucose less than 1.5 will lead to burst suppression, vascular brain injury, and of course brain death all cause burst suppression. Do our anaesthetic agents suppress the brain equally though? They all have a constant phenotype. They all seem to look like they do the same sort of thing, but do they actually? Well, let's think about burst suppression as a measure of anaesthetic potency. So we're all familiar with the concept of MAC as a construct based around movement. But if we think about using burst suppression with our vapors, we have to give more than a MAC of vapor to burst suppress the brain. So to produce burst suppression in 50% of patients, we give 1.5% isoflurane, which is 1.3 times MAC. Sevoflurane, 2.9%. Which is 1.4 times MAC. Propofol is a bit funny. So to cause burst suppression in 50% of patients, we give a plasma concentration of 4.9 mics. However, to stop patients from moving, we'd need to give 15.2 mics per mil. Propofol is brilliant at suppressing cerebral function, but does not suppress spinal function as well as our vapors. And this is particularly important for those starting out with TIVA, appreciating the fact that movements may still occur as spinal reflexes when using propofol because it doesn't suppress spinal motor neuron function as well as our volatiles. Kind of adds weight to the fact that single agent propofol anesthesia, just using propofol, is genuinely not a particularly good idea, because there may be some audience participation. So who's at risk of burst suppression? Well, with increasing age, the incidence of burst suppression becomes more likely. It affects males, or is found in males more than females, may well be because it's also associated with coronary artery disease, which has a male preponderance, of course. So older males with coronary artery disease. How often do we see burst suppression? Well, the big trials that have looked at burst suppression and BIS values of less than 40 identify burst suppression occurring in around about, in the CODA trial, it happened at for about 12 minutes and around about 14 minutes or so in the ENGAGES study. They were looking at whether or not using a processed EEG monitor would reduce the incidence of burst suppression and then reduce the incidence of delirium. Both papers found that yes, if you use a processed EEG monitor, your patients were not as burst suppressed as they would be if you didn't use a monitor. However, CODA demonstrated a reduction in delirium, ENGAGES didn't. The reasons for that we'll explain when we talk about the vulnerable brain. I'm just going to mention for a moment this BIS value of 40. 40 is important because this is the value below which you start to see burst suppression on the BIS monitor, but it's actually a little more subtle than we might imagine. Let's relate that to delirium a little bit. So this is a meta-analysis looking at whether or not use of a BIS monitor will reduce the incidence of delirium. The top papers are hip fracture sedation studies, and demonstrated that using processed EEG monitor in patients who were sedated did reduce the duration, certainly in the first paper, of delirium by up to 1.5 days. But these patients were actually quite deeply sedated when in the control group, which were blinded to the BIS monitor numbers. In general anaesthesia, some papers do show a reduction in the incidence of delirium. Engages didn't, for reasons which we'll come to, but the overall effect was a reduction in the incidence of delirium. Cochrane quantified this at somewhere around about a 32% reduction in their 2018 publication. It's noted that the duration, or how long our patients are burst suppressed, increases the incidence of delirium. So when we get to over 4.5 minutes of delirium, of burst suppression, sorry, we're starting to see a very significant incidence, and that's why that suppression time value that the BIS update will bring will be quite valuable in quantifying that for us. But the BIS algorithm gets a bit confused with burst suppression. So if you imagine we've got this flat line and then we've got this big burst of activity, the monitor gets a bit confused and thinks that burst of activity is a patient that's starting to get a little bit frisky. And the early first two versions of the BIS algorithm were producing quite high values, which were paradoxical to the depth of hypnosis that the patient was actually experiencing. So another variable was introduced into the algorithm called quasi, which has never actually been, its derivation hasn't actually been published. But what it seems to do is smooth the region in the BIS monitor algorithm between the values of 30 and 40, where the patients are starting to show some burst suppression. And this matters because what the BIS monitor does is it doesn't use the suppression ratio value unless it's more than 40%. That means your patient has to have 26 seconds in every minute of an isoelectric EEG before the BIS value starts to reflect that. There's a plateau range in between 30 and 40. When we get over 40, for every one, we'll see a 1 index value reduction for every 2% increase in burst suppression, this linear decay. And this, as I say, there's a great area of values between 30 and 40 which describe a huge range of brain states, and why you can see things like this. This is a very, very flat looking EEG. I would suggest this patient is significantly over anesthetized, and they've got a suppression ratio of 20, yet a BIS value of 40. So that's because this suppression ratio hasn't tripped the algorithm into using the suppression ratio to reduce the value further, because we haven't got above 40. So that's one of the features of the BIS monitor. Many of these monitors were designed and calibrated around the absence of recall rather than deep anesthesia. So I do strongly believe that the EEG should be shown large so we can make these deductions and adjustments to our anaesthetic ourselves, rather than just relying on these very fairly simplistic and crude dimensionless values. So let's bring this into the vulnerable brain where we really want to go, which Rob was describing a patient at the beginning there on a trauma list who almost undoubtedly will have a vulnerable brain. So what do I mean by that? Well, as this alpha power falls, these colours become less warm, the probability of our patient becoming burst suppressed increases. Brains with low alpha power seem to be at a high risk of post-operative delirium. Indeed, a study out at the moment, which I'll mention in just a moment, from Oluwaseun Akeju's team, looking at cardiac patients, which are a great model that's used quite a lot in EEG monitoring, demonstrated that a low alpha power quadrupled the incidence of delirium. So if we look at these little traces we've got here, there's a nice example at the bottom of that old brain, young brain phenomena I mentioned earlier. These are two patients, very similar age, but quite different looking density spectral arrays. We can see that bands of alpha oscillations here in orange and red, and then on this side, same age patient, same sort of surgery, with absolutely absent alpha oscillations on this particular calibration of the density spectral array. But is it just down to age? Well, frailty also seems to cause problems, and there's quite a lot going on this graph, but this is one patient having 3 operations over the course of a year. The first operation was a coronary artery bypass graft. The black lines indicate where the patient went on to bypass. There's a lot of burst suppression happening there. Temperature falls a little bit, but we've got these alpha oscillations visible as these yellow and orange bands. This patient required a mean end-tidal ISO level of 0.86. The poor guy then developed a type B aortic dissection and came back for further surgery. This is the period on bypass, a lot of burst suppression, obviously cooled for deep hypothermic circulatory arrest, but we can start to see these bands becoming a little bit less obvious. He required at this point just a mean end-tidal ISO concentration of 0.65. The endograph then got infected and he came back for further surgery. Now, between these operations, he'd had some CT scans of his upper body, and they were the radiologists were able to make measurements of his quadriceps muscle bulk and his TMJ muscle bulk, which are indicators of sarcopenia. And they were able to demonstrate, as well as his chronicity of medical problems, that he was becoming increasingly frail and sarcopenic. The last operation was when he came back with an infected endograph and went back to theatre. Fortunately, didn't need bypass. But we've now got very, very little of this nice alpha stripe, and he's requiring an extremely low end-tidal anaesthetic agent concentration to maintain an appropriate looking EEG. And I'd wager that without processed EEG monitoring, in all of these cases, he'd have significantly more vapor administered than this and would spend very much longer in burst suppression. Looking at the strength or the power in that alpha band in between these 3 operations, we can see a really rather marked deterioration in this gentleman's brain production of alpha waves as he becomes increasingly frail. Now, of course, that's just a case report, but looking at a much larger group of 300 patients, again, having cardiac surgery, what we want to see, this isobologram is showing us as the amount and significance of comorbidities increases and a patient's age increases, so we see a fall in their alpha power, these cool colors here. This graph here shows us patient-reported outcome measures for their physical performance. This is preoperative physical performance. So patients with poor preoperative physical performance were more easily burst suppressed. They also have a lower alpha power. So something about patients who are frail, patients who have multiple comorbidities, they also seem to have some markers of an older brain. The low alpha power is also found in patients with preoperative cognitive impairment. And it's interesting to look right back to the early 2000s and the aspect, the company behind the BIS monitor were investing around about $5 million a year in research. And one of their research programs was looking at using things like BIS monitoring to identify the early onset of Alzheimer's type dementia from the changes in the brain waves that can be seen. In fact, anaesthesia has been used in the past by neurologists to emphasize and exaggerate the brain waves. Our anaesthetics have a wonderful effect of hugely increasing the amplitude of the brain waves in the frontal cortex, allowing more easier deduction of the underlying rhythm. And there were neurologists in the States using doses of thiopental in patients with Alzheimer's to accentuate these waveforms to try to make an Alzheimer's diagnosis. So Sun and their team, who were interested in sleep, came up with the idea of brain age. So what they did is they looked at 5,000 EEGs performed during normal sleep. and they were able to look at a number of different features of the EEG, from the power of these different waves, the total brain power, etc., and come up with an idea of normal and what that would look like. And they then looked at cohorts within that big group with various different diseases and calculated their brain age. The difference between your actual chronological age and your brain age is known as your brain age index. If we look here, this is years along the bottom. This is patients with significant neurological or psychiatric disease in the salmon colour, and blue for people without that. We can see that people with underlying neurological and psychiatric problems have brain age, which is in excess of both their chronological age and also a healthy matched peer. And the same with hypertension and diabetes. So our patients with these problems have accelerated brain aging. Whether or not this is related to microvascular disease remains to be unpicked. But the concept of brain age isn't unique to anaesthesia. It's also noted in sleep. I would not want to be this person right out here whose brain age is some 30 or 40 years in advance of their chronological age. But this is something that I think we sometimes see on the EEG. Let's put this all together then. So Michael Avedon's group showed that intraoperative EEG suppression at lower volatile anaesthetic concentration predicts postoperative delirium occurring on the ICU. And remember, in the States, where Avedon and team are from, everything's ITU, I think. So if our patients are producing an isoelectric EEG or a positive burst suppression value at what we consider to be a normal or satisfactory age-adjusted MAC or propofol concentration if we're using TIVA, then this is an at-risk brain. He demonstrated that the odds ratio for delirium in this cohort was some 2.6 times higher than if patients didn't have burst suppression. So these vulnerable brains have an increased incidence of delirium. We can't identify these patients unless we use a BIS monitor. I think there's far more to processed EEG than just being something to do with awareness, which was the marketing gambit in the late 90s and early 2000s. The brain is trying to tell us much, much more. Putting this all together from a basic sciences point of view, this is from Emery Brown's team, very, very influential group. The brain's an interesting thing. Around about 80–85% of ATP is produced by normal oxidative phosphorylation, but 10 to 15%, which is really important, is produced by something called aerobic glycolysis, which produces lactate for neurons. This happens in the astrocytes rather than the actual neurons. This is affected by aging. The brain does not produce as much aerobic glycolysis and as much lactate, and also can't recycle as much of its ATP as we get older. Anaesthesia is a mitochondrial poison and reduces the amount of ATP our mitochondria can produce, making our patients more reliable on this pathway, which is the one that's knackered by aging and other medical conditions. So we end up with a state with a brain that cannot produce very much ATP. And this may be why the brain is susceptible to burst suppression under the influence of anaesthesia. These astrocytes also support the neural network in maintaining oscillations. And should this anaerobic glycolysis be poor, our oscillations are going to be lower amplitude and more difficult to sustain, again making our patient's brain more likely to be burst suppressed. So let's look to Jamie Slay from New Zealand, a gentleman who can produce either an editorial or a major research piece every other week from the University of Waikato, the biggest place I've never heard of in New Zealand. Absolutely sensational talent. He summarises that burst suppression is a marker of an abnormal brain response. Low alpha power or increased burst suppression are important, easily obtained markers of physiological functional brain fragility. Burst suppression warns of a high likelihood of postoperative problems and could allow us to individualise our patient care plans to minimise delirium. Without processed EEG, we're flying blind, and I'm unable to identify these vulnerable patients. I think it's easy to recognise. Here, 74-year-old, look at the size of these alpha oscillations on this EEG as this patient undergoes laparotomy. Here's a 60-year-old having vascular surgery, and look how flat that line is. Importantly, these are both at the same calibration. Our machine is indicating this is a satisfactory depth of hypnosis. Yes, it is, but the alpha oscillations are very small. I'd expect more problems from this patient than I would do from this. I suspect this patient will wake up very, very nicely with their young, older brain. Vascular patients, of course, have a full house of comorbidities. They're also probably more susceptible to anaesthesia, as many of them are smokers, and smokers seem to be more susceptible and require a lower MAC value, maybe because of microvascular disease in the brain. A couple of practice points. So this is how I would set up my BIS monitor. I'd ensure that the suppression ratio was on. I'll show you how to do that if you wish. I turn the filter off whenever I can to accentuate these slow wave undulating oscillations over which my little alpha sawtooths are sitting. I make the EEG the dominant feature to allow me to pick up that suppression easily, and I make the secondary variable on my BIS trend the suppression ratio, so I can look to correlate that with the BIS index. I aim to keep the suppression ratio to 2, but if there is burst suppression, I think to myself, is this a patient that's excessively anaesthetized, looking for other markers, heart rate, blood pressure, etc., and the absence of any other sympathetic stimulation, of which I appreciate is a variable use. I look to optimize cerebral perfusion and oxygenation, blood pressure, saturation, etc. And I then wonder to myself, is this the vulnerable brain phenotype, and do I need to be doing anything about that? Final word to Jamie Slay. If you give a patient a general anaesthetic, you should think of it as a brain stress test. If you see low amplitude power, not much alpha, or a lot of burst suppression, the patient is waving a red flag, shouting, "I've got brain frailty," or a high brain age. If you don't look at an intraoperative EEG, you will never see this information. The interventions could include anything from avoiding sensory deprivation, so making sure they've got their glasses, hearing aid on, from the moment of wake up all the way through the rest of their inpatient stay, avoiding benzodiazepines and anticholinergics, reducing opioid use with some regional or neuroaxial techniques, the appropriate nursing care, both in intensity and location. And then I think something we should do more of, which is involving healthcare of the older person. I think that really the concept of orthogeriatrics should be spread into general and major surgery too, because that is the intervention that really does reduce the incidence of delirium and shortens its duration as well, with enormous financial and savings for patients, their relatives and families. I'll delighted to take any questions. I've got here at the end of the talk, I've got a large repository of podcasts, review articles, websites, YouTube videos, which are a brilliant way of learning the basics of EEG and density spectral array. I can make those available if people want. There's 5 on there which are particularly brilliant. This is definitely the direction of travel in anaesthesia, and I think processed EEG monitoring will become a core monitor within the next 5 to 10 years as technology continues to improve. Thanks very much.